My name is Paul Frankish. I'll be the moderator for today. Our first speaker is Dr. Dan Hines, who joined our department last year. Dan went to school at University of New Brunswick, Fredericton for his undergrad, then attended grad school at UP Vet College and ultimately Dalhousie for med school. He hails from Riverview, New Brunswick, so he's a local boy. A fun fact about Dan, he is the proud owner of a certificate of appreciation from the Ecuadorian Navy for volunteering as a diver to clean up garbage from a harbor in the Galapagos Islands. Dan's going to be talking to us about sodium bicarbonate in cardiac arrest and telling us if there's really any benefit to using it. So I'll hand it over to Dan.
Thanks, Paul. We'll just get things going here. So, like Paul said, we'll be talking about sodium bicarb today. And thanks for everyone for tuning in. Just as a quick disclosure, I don't have any financial holdings in Arm & Hammer or any medical technology of any kind for that matter. And just to put my bias up front, going into this, I had a bias towards the physiologic rationale for using bicarb in prolonged arrest situations or presumed significant metabolic acidosis. And that's kind of what got me interested in this talk and trying to look at what kinds of medical therapies can we do for these people that have quite prolonged resuscitations and things like that. So to put things into context, I just want you to think about a case as we go through today's talk. And so you can imagine yourself working in acute and you hear a patch from EMS, and there's a 76-year-old male who had a witnessed non-traumatic cardiac arrest. He had bystander CPR. There's 2 defibrillations on scene. There was no ROSC. They're planning transport to the ED, and there's a CPR duration in the field of approximately 25 minutes. As you're pre-briefing your team in getting everything organized, someone asks you, what medications do we want brought into the resuscitation room? Do you want us to prepare some bicarb? That leads us into today's talk. This isn't a deep dive on acid-base regulation or renal tubules, but I thought it was prudent to just bring this up, that we're talking about acidosis in both of its forms, either metabolic or respiratory. And so in cardiac arrest, there's an apnea period where there's poor ventilation, as well as poor tissue perfusion leading to a metabolic acidosis. What we're talking about doing is giving more bicarb to try and correct this hydrogen ion overload with an expected rise in CO2. That's in essence what the whole goal for this therapy is. At a cellular level, this is a fairly intimidating looking slide for people that don't like cellular physiology, which kind of is myself included. However, the whole goal is to say that all of these ions and products are actively transported in some way, and that CO2 diffuses across the cellular membrane and does not need any cellular transport of any kind. So that's important to keep in mind as we go through the talk for what happens when we give this drug and what are the expected outcomes of giving this drug. So you might be wondering, how long have we been using this drug and how much evidence is there behind it? And that's what we're going to go through. And some of the early reported uses I found for it was in the First World War. It was given to soldiers with sepsis and acidemia. There's not much actual literature I could find. There's a lot of anecdotal stuff mentioned in papers, but it was given to relieve the air hunger of sepsis. And so in very sick patients, they gave it intravenously and it improved their ventilatory status, presumably. And so what I found for actual documented evidence around scientific inquiry for this begins in the 60s. This is with Thrower's Archives of Surgery paper in 1961. He had a canine model looking at the effects of acidosis on ventricular contraction force and blood pressure. They measured the ventricle contraction with devices sutured onto the ventricles and gave these canine models a continuous infusion of lactic acid to drop their pH. And then they gave them norepi and epi and measured the effects. And they said at lower levels of pH, there's poorer contraction and poorer blood pressure response to vasopressors. They went in then and corrected the acidosis with bicarb and improved the contraction and blood pressure response. So based on this, they said vasopressors at low pHs have less effect, and we should probably try and correct the pH if we're going to use vasopressors. This led to Leroy in anesthesiology have a cardiac arrest model for canines where they induced VFib under light anesthesia. They allowed the VFib arrest to go on for 5 minutes and then started CPR. And at 7 and 8 minutes, they used experimental drugs, either bicarb or epinephrine, and then defibrillation at 9 minutes. When they had a successful defib and ROSC in the experimental procedure, they repeated it in those animals to get their numbers up. But what they found is that when you combined bicarb and epi, you got a much higher rate of ROSC in these animals. Now, these were small groups in each of their experimental groups at 5 dogs per group, and their repeated measures bias. But it led them to say, this is probably something we should do. In the same volume of the same journal, Pearson had a hypoxic arrest model and tested bicarb and phenylephrine as his experimental drugs, and found that when you combine phenylephrine and bicarb, it seemed to be no different than bicarb alone. Of note, looks like a large dose of phenylephrine that they were using. So this went back and forth, and there's some other comments about this in sort of lab-based literature, which led to Max Minnak in CMAJ in 1965 to pull together all of what was known about the drugs used in cardiac arrest and produce a review for it. Of note, at that time, vasopressors were delivered intracardiac, and he's produced a figure here for recommended approaches and landmarks for it. And when you look at the drugs he reviewed, it just gives you an idea of what they were talking about and what was known at the time. He notes that the use of potassium chloride was very effective for treating VFib, but the asystole that follows was very difficult to treat, and mentions the same thing about procainamide. And so when he comes down to bicarb, he says that there seems to be an adverse effect of acidosis on vasopressor drugs, and that anecdotally they've begun to use sodium bicarb in the treatment of cardiac arrest, and their impression is that the patients respond to treatments more easily. So overall, in the 60s, we have a fairly positive trend towards interest in bicarb. Leads us to the 1970s to 90s, where further inquiry went on. And in this observational case series, Bishop was interested in just knowing what was going on at the pH level during arrests. And so they responded to in-hospital cardiac arrests, and they found 7 patients that met their criteria. They included 6. And they took ABGs of those patients as soon as they arrived on scene. And the first gas was taken approximately 15 to 30 minutes after CPR was started, with a range of 15 to 180 minutes. What they found was that the pH was actually reasonably well managed by what he says is good ventilation and compression, and that the PCO2 was not catastrophically high in these cases either. They then gave experimental bicarb to these patients, and they did rise their pH, and they also rose their PCO2. The 7th patient that they mentioned that they didn't include had an esophageal intubation and had a precipitously low pH in the 6.8 range and a very high CO2. So their conclusion was that as long as you're giving good compressions and adequate ventilation and the ET tube is in the trachea, you can manage the pH and CO2 okay. And if you give bicarb, there's a potential worsening of intracellular acidosis as this CO2 crosses from inside the cell to outside of the cell and suppress the myocardial activity further, potentially worsening your efforts. Furthermore, in 1984, in the Annals of Emerge, these authors took a look at the AHA guidelines at the time, and they cited 5 concerning features of using bicarb from a physiologic basis. And their essential conclusion is that we're not sure if there's any obvious risk. There doesn't seem to be detrimental side effects in terms of resuscitation rate, but that we don't know, and that these things are all worrisome. Young published in Journal of Emergency Medicine in 1988, very similar concerns around the use of bicarb, citing most concerned about the intracellular and CSF drop in pH, as well mentioned that perhaps by doing this, we're actually increasing the hemoglobin O2 affinity and worsening oxygen delivery to the cells. So the 70s to the 90s saw a little more question around, is this of any benefit? There seems to be some physiologic rationale for making matters worse, not better. Throughout the 90s, we see a review by Christensen and CMAJ in 1993 of the 92 AHA guidelines. And the AHA came out to say, these are our recommendations for when sodium bicarb should be considered and when it's helpful. So they come right out and say, use it for treatment of hyperkalemia or hyperkalemia arrest. TCA overdose seems to be reasonable, but there's some gray area around bicarb responsive metabolic acidosis, and that's possibly helpful around intubated patient with continued long arrest or upon ROSC after a long arrest interval. And this essentially is the question that's being asked is it helpful in these patients? And the AHA in 92 haven't come out and given any more clarity on this. They do say that in hypoxic lactic acidosis, it's not indicated or possibly harmful. I think that this is probably due to the CO2 that you get in the hypoxic arrest. In 96, Vukmir and AGEM pulled together a review, not quite a systematic review, but a review of the animal models and human data around sodium bicarb experimental use. And so in all of the animal models, it seems like the majority have no effect or worsen things. And it seems a little more split, and there's an age or a year bias here, that the more recent evidence that he was able to obtain would suggest no effect. His conclusions are that extremes of either end of physiologic pH are probably bad, and that above 7.5 and below 7.1 were likely going to be associated with adverse events. And ventilation must be maximized to vent off the predictable rise in CO2 if you're going to use it. He advocates that dosing should be guided by either base deficit or pHs, either venous or arterial. So what's gone on in the last 20 years or so? In 2001, this study in canine models in resuscitation was published. This was another VF model where they induced VF using AC defibrillation. They allowed the arrest to proceed for 10 minutes, followed by usual ACLS care, and had 2 experimental groups to assess the impact on bicarb. And they were looking at, does immediate defibrillation of VFib or medical optimization first, followed by defib, work better? And does bicarb have any impact on that? What they found was that there's a predictable rise in CO2 and that we predictably increased pH, and their starting pHs were a little low. And I think that that probably is due to the duration of their arrest. But what they found, and they measured coronary perfusion pressure, and I think that that was to look at a surrogate for blood delivery to the heart and how well heart is pumping. And they found coronary perfusion pressure was higher in the bicarb groups, both of them, and that they required less defibrillation attempts, which led to a reinvigoration of the interest in sodium bicarb in this particular application. In this multi-centered, double-blinded RCT run over 4 years in Pennsylvania, there were 870 subjects. They found no difference in the primary outcome of survival between sodium bicarb and normal saline control groups. However, there was a subgroup analysis done, and it was not an a priori defined subgroup. It seems to be a subgroup that evolved out of interest in the study of the patients that had a prolonged resuscitation that they defined as greater than 15 minutes. That group had 320 people in it. In the survival sodium bicarb group, there were 19 survivors, and in their control, there was 8. And they say they've got small numbers, but there seems to be a potential benefit there. And advocates to reopen the discussion around the benefits in prolonged resuscitation. This is a propensity-matched multivariate linear regression analysis in a cohort retrospective database study taking place in Taiwan. They had around 5,000 subjects, 3,700 that received no bicarb and 1,800 that had received bicarb. It took place between 1997 and 2012. And their observational study data would suggest that there seems to be an odds ratio benefit towards people that received bicarb for whatever purpose. These were all comers cardiac arrest, and they just looked at their medical therapy. And this just added more discussion to, is there a potential benefit here that we're not seeing? This is a very small randomized pilot study of 25 patients per group. And this targeted patients with the most likely presumed benefit. And so they included patients with an arterial pH of less than 7.1 or bicarb of less than 10 at 10 minutes during a resuscitation. They randomized them to receive saline or bicarb, and they found no difference between the groups. Their ultimate conclusion is that there's no difference in ROSC or neurologic outcome, but that it's small and maybe larger trials would be warranted. This is all kind of culminated in the last 2 years with 2 systematic reviews. This is the more recent of the 2. And this is effects of sodium bicarb on all of the studies that met their criteria on rate of ROSC. And you can see this is that one RCT we just talked about. And so it pulls things a little bit towards favoring bicarb, although I'm not really sure how. And in these observational studies, it pulls things a little bit more towards favoring control. When you look at patient-oriented outcomes in terms of controlling for heterogeneity and looking at survival to discharge, it seems to center right around 1, suggesting that there does not appear to be an actual observable benefit. And their conclusion is that sodium bicarb should not be routinely recommended for out-of-hospital cardiac arrest. So what does all this mean? The correction of assumed or documented metabolic acidosis with sodium bicarb seems to be or make physiologic sense, and there is some empiric lab benefit, showing that some of our medications can improve circulatory metrics. These are old studies and they're in animal models. There's been a failure, in my opinion, to demonstrate a consistent observable benefit in sodium bicarb during cardiac arrest over several decades. And there are very specific situations where it makes physiologic sense and will have benefit. And those two, for example, are TCA overdose, where the sodium concentration has physiologic benefit overcoming the sodium blockade, as well as hyperkalemia, where the serum alkalosis shifts the potassium via the hydrogen potassium transporter that we mentioned on the start of this talk on the cell surface. Overwhelmingly, a lot of the themes that came out of all these articles was that adequate ventilation and good quality CPR remain the highest priority. And that if you're going to use sodium bicarb, it's not necessarily wrong. There's not been a lot of harm demonstrated, although the perceived harm very much comes from the hypercarbia associated with it and the alkalosis. And so if you're going to use it, perhaps some blood gas that guides you and optimizing or maximizing your ventilation seems to be very important. And so circling back to the case at the start, someone asks you, are you bringing sodium bicarb into this resuscitation with you? I just want you to think about next time this happens, are you going to be saying yes, prepare it, or are you going to use that person to be delegated towards some other part of the resuscitation ergonomics ongoing? Thanks for listening.
Thanks very much, Dan. I think I can probably join everyone in saying that was a very fascinating deep dive. I had no idea the literature kind of underlying use of not only sodium bicarb, but again, some of the vasopressors and how far back that dates historically. Just to start off the discussion a little bit, I just wanted to sort of throw my own 2 cents in. I have generally tried to put people into like 1 or 2 camps when I see that they are more of like a prolonged arrest scenario, particularly if they're PEA and rhythm. And it's mostly been either historically, do I think they fit one of those scenarios where sodium bicarb or calcium may be useful, as you point out, the hyperkalemia standpoint, or maybe I presume toxic ingestion, TCA. But there's some talk of maybe just looking at the PEA complex or printing off a strip during a rhythm check. And if it's a really bizarrely wide PEA complex, more likely that they have a metabolic underlying trigger, in which case maybe it's giving the sodium bicarb has more benefit. Again, it's not evidence-based, it's just an algorithm that's kind of been presented that inherently made sense to me. Any thoughts on that?
Yeah, I think that I think it's always tough to identify a tox arrest or a metabolic arrest that would be responsive to this type of thing. Certainly, you don't know very much. And if there's a clear electrochemical rhythm that you can identify that classically would respond to this type of therapy, I think that entirely makes sense. If it's a narrow PEA, maybe a tox ingestion or a metabolic cause may be less likely, in my mind at least.
Awesome, thank you. Any other comments out there on the talk? We've got lots of time for discussion in this case, since Dan stayed right on time. Oh, James has his hand up. We weren't that lucky on the whole camera thing.
Just was going to tweak one word in your conclusion, which is your second line indication for bicarb, which is in hyperkalemia, the metabolic alkalosis that it causes through shifts and effects on antiporters helps correct hyperkalemia. What I would say is that in patients with a metabolic acidosis and hyperkalemia, bicarb is the fastest way of correcting hyperkalemia. And if you don't do that, then you're going to really struggle to do it with other things that would cause shifts. Particularly you've got a uremic patient who's got a metabolic acidosis and hyperkalemia, giving sodium bicarbonate as a low volume solution that will give you a rapid correction of K+. And that was all I was going to say.
Thanks for the tweak.
Can I just ask as a follow-up to that, James, in terms of any suggestion of evidence of how much? Like, are we giving a single amp of bicarb? Are we giving 3? Is there evidence to support one over the other?
Nope.
Perfect.
And the only other thing I'd say is that as soon as you give it, if they've got circulation, then their end tidal, in terms of maximizing ventilation, Dan, their untitled CO2 is going to shoot up, and you see it as soon as you've given it. That's kind of how I tweak the ventilation. If I was going to have a kind of immediate bedside, I'd look at their pre-bicarb end tidal CO2, give them bicarb, and as soon as the CO2 shoots up, I'd up their minute ventilation to break down to a pre-bolus end tidal CO2, again based on no evidence, just what I've seen.
That's a common approach that people have talked about that I saw. And I didn't include it mostly because I didn't go into too far how much end tidal correlated to serum CO2. But I think that's a reasonable and pragmatic approach.
And I think inherently that makes sense. Again, this is the argument on why sodium bicarb makes no sense in severe DKA, because if you can't breathe off the CO2, you're not having any benefit. Those patients are already breathing at a minute ventilation that you can't maximize any further. But I think inherently it makes sense in this scenario if you're adequately ventilating the patient.
Great. Thanks a lot.
I love the, thanks very much for that talk, Dan. It's